Good morning. How are
Thanks
you?
for doing this.
My pleasure.
Anything special you I give a less than a minute introduction, especially when I said. So one of the things I was trying to get people to recognize that developing scientists are going to be working in research teams. So if you have any time along the way that you want to say anything, how are you able to conceive of team that includes epidemiologists and biostatisticians and other kinds of professionals that they won't be probably. That'd be great, but struggle to do it. It's not easy, but.
Oh no, I've never done anything by myself, so that's easy to talk about.
Right. Good. And she's in the past with Prevalence.
Okay. This would be very similar.
We don't always have somebody coming in on site, but I'll check with you before we actually start, because if there are people outside, these microphones were sort of for picking up comments from the audience, but not so great. So if people ask questions, you could just repeat them so that it's probably a good practice just to make sure you heard the question right anyway, but you give everybody a chance to hear how you interpreted the question.
Also, this is not didactic.
That's right. Right. And so far this group has been, there's at least 3 or 4 people who are willing to engage in dialogue if you want to try to a little bit of discussion of anything. So.
Oh, that's good, because my last section is
Great.
if I can get it. So yes, if you want to talk about stress and teamwork, I guess mentioning that I'm a member of the biostatistics, epidemiology, research and design group, and that my research is largely coming back to collaborating on a bunch of other.
Yeah, I was going to actually just mention all the centers you're associated with, which is typical. So it's good. So do you sit in one of the bird sessions every week or two, or is it more of a sort of consultant or people in your special skills?
Yeah, I am not currently part of any of the sessions. I am part of the team award program.
Okay, yeah.
And so I'm more on the sort of mentoring and one-on-one side.
Okay, thank you for that. We're glad that's better every year. It's great.
Yeah, I know the first year is looking good. It's good looking good.
Right. No, it's still trying to come up with 10 people who are willing to take a year. Their professional training doesn't happen easily, but let's get going. I think they're set up already. So we have a little bit smaller group than last year, but it's a few people involved in installation stage, so we always have to start when they've gotten here. But I'll wait until 4 hours. Okay, thank you. Mention. So, we always get feedback from people. If there's anything specific you'd like us to ask about, questions, content of the lectures or your style or what you expect of people or anything, we can add that in. So, I think Gene usually asks speakers if they have anything special. included in our survey. It'll go out for a couple more weeks because we do sort of modules at a time.
Okay.
But if you have lots of things you like, specific feedback on.
I mean, I guess just this is useful because, you know, I just
We'll
recharged
sort of ask that, yeah.
with, you know, my entire display
Right,
in 2 hours, which is,
Right. It was, yeah, I think, I mean, my sense is that people find it really valuable. First, I have a face, I'm a listener, so I know but it's the sense of but you're right, it may be, some people try to do sort of example case-based things, think it makes more sense, but it's hit or miss whether you get cases that are relevant to the group, and other people have different ways. So, listening has been very appreciative of what people think. So, any critique they give is always very positive. They're going to make sure that the experience will be good and maybe a little bit more. So, it's good. Okay. How are you doing?
good, how are you?
Great. See you.
Nice to see you as well. Sorry, I am terrible with names. You're my name.
I do classes. You know, we were in David's community together.
Okay.
Which might have another thing like a chair.
Yeah, thank you.
Okay, and next door, we'll have a question.
Okay.
Health administration.
You know, did you move on to the positions?
In Georgia, all those. About these papers, last time I heard, I provided some data on it is going to be some additional analysis. I have heard some good heroin parents. Yeah, she was that can be very valuable. There are a lot of politics.
Okay, well, go ahead and get started. Good morning. So this morning we have Dr. Emily Levitan here for an overview of the broad field of epidemiology. Dr. Levitan is associate professor in the School of Public Health in the Department of Epidemiology. She got all of her initial training at Harvard University, where she got a master's and science doctorate in epidemiology, and then was a research fellow in the Cardiovascular Institute there, doing cardiovascular epidemiology research. And cardiovascular disease has remained a real focus of her research since she's been here, it's here in 2009?
2009.
Right. So she's particularly interested in epidemiological aspects of atherosclerotic cardiovascular disease, and the interplay between obesity and cardiovascular disease, a number of other things. But I think one of the things that you'll recognize if you had a chance to look at her CV is that, she's totally invested in team-based research, and that part of the way she expresses this is she's made associations with a lot of different research centers around the campus. She's a scientist in the Comprehensive Center for Healthy Aging, in the Nutrition Obesity Research Center, the Diabetes Research and Training Center, the Outcomes and Effectiveness Research and Education Center, Comprehensive Cardiovascular Center, and the Minority Health and Health Disparities Research Center. And I hope along the way she may give you a little bit of a sense of how she approaches working in different types of teams. And one of the things are not so subliminal messages to you all is to be thinking about the extent to which, even if you feel like you work in a very self-contained group, your group is part of, has team members, and you are working in teams, and so to learn best practices of how teams work. We'll have a special session on that in a few weeks, but it's something you ought to be trying to keep in mind and see how people develop careers where team science is one of the major ways they operate. So thanks very much for joining us.
Okay, thank you. Good morning, everyone. Please let me know if you can't hear me. I try and speak loudly, but my natural tendency is to get quieter as I'm talking, so wave at me, please. And stop me if anything doesn't make sense. You know, I think that there's no need to make this particularly formal. So I have given sessions like this in the past. It is a challenging thing to do because it's, you know, my entire field in 2 hours. So, you know, what I'm going to try and do is talk to you about some of the important things to consider if you are doing epidemiologic or observational research in general, and then also give you some resources for further study, and then also for some of the resources that we have here at UAB that will help you with these kinds of studies. So agenda, first to talk about what epidemiology is, talk about some of the types of epidemiologic study designs we use, talk a little bit about correlation and causation. So one of the trickiest things about observational research in general and epidemiology in particular is trying to figure out, is what we're seeing really cause and effect, or is it something else? And then talk about developing a testable hypothesis. This is something that is surprisingly difficult to do. It seems like it should be straightforward, but to actually come up with something that you can, a question that you can actually answer, is a learned skill. And then talking about how to design an epidemiologic study, so we'll walk through sort of some of the design considerations, and then finally some resources. So what is epidemiology? There's the classic definition, McMahon and Pugh, from a textbook, is the study of the distribution and the determinants of disease frequency, which is a good definition. That's pretty much what it is. When I talk to people who are not epidemiologists, who many of whom think that I am actually a dermatologist, I talk about study of health and disease at a population level, because that's sounds a little less formal. So the types of questions that we look at as epidemiologists is things like how many people have a disease, how many people develop a disease, right? So the first question is about prevalence. So, you know, looking at a cross-section, how many people in your population have a disease. The second question is about incidence, and that's how many people are developing disease. And those are two different things, right? So they're related, right? Because people who have a disease have to have developed it. But they also have other aspects to them, right? So if you have people, you know, the prevalence of breast cancer is much higher in the population than the prevalence of lung cancer, and that's for two reasons. One is that the incidence is higher, but probably even more importantly is that people live for a long time as survivors of breast cancer. People do not generally live for very long as survivors of lung cancer, right? So you've got both the how many people develop disease and then how many people are surviving with your disease. You have other issues of, you know, with colds where people are recovering from disease. So they're coming out of that prevalence pool. We talk about how quickly do people develop disease. So that's, you know, rates of disease, like, and then who are these people? And ultimately, what we usually want to know is what causes disease, right? So the first four are fairly straightforward. They're not easy necessarily, but this last one is the one where things get really tricky. Any thoughts or questions so far? So, I think that a lot of times when people think about disease, when they think about epidemiology, they're thinking about infectious disease. But in fact, we're just defining disease broadly. We're talking about chronic diseases. This can include, mental and physical health, and we're talking about injury and violence. So, we're really talking about all the sorts of conditions that can adversely impact people's health and well-being. And recently there's been more of a focus, particularly in the cardiovascular field, where we're thinking about not only are we preventing disease, but are we extending people's healthy lifespan, right? So we don't want to necessarily extend people's lifespan when their quality of life is very bad. So I swear I wasn't set up for this, but so I had this slide even before I understood that that one of the themes of this session was, or of this series of talks was about team science. But epidemiology by nature is interdisciplinary. And so I put epidemiology in the center. I don't actually think epidemiology is the center of the world. But from my perspective, this is sort of what it looks like. So epidemiology as a field draws from a lot of different fields, including medicine, biology, statistics, logic, economics, psychology, and sociology. But also, we have borrowed pretty extensively. Epidemiology is a pretty new field. So we borrowed extensively from other more established fields. But the other thing is that we collaborate really very much. So you will rarely find a epidemiologic paper, where it's all epidemiologists. There are some, but there's not that many, right? So, for the projects that I work on, I have no clinical training, so I've picked up a good bit about medicine over the years, but I am by no means a clinician, so I will usually be working with people from medicine, from nursing. Depending on the question, we sometimes will bring in collaborators from biology, or I will be brought in as a collaborator for someone who is very biologically focused. So for example, when I was a postdoc, there was another postdoc in the same training program who was looking at aging in mice. And so, the statistics that they used tended to be very much like, t-tests, like this group versus that group. But when they had this aging program project, they have some mice that are developing, they have these mice living for a long time, and some of them are developing a condition of interest, and some of them are dying from other causes. And so, we were really brought in to do this epidemiologic study of mice because the sort of lab science statistics weren't quite good enough for the questions they were trying to answer. I work very closely with people in statistics, depending on the project. So utilization projects, we tend to work with people either in healthcare organization and policy, which tends to have a lot of economists, or from healthcare administration. And it really depends on the question of interest. So I'm going to talk a little bit about the different types of studies we use. So the basic sort of foundation of epidemiology, and this is honestly not something I have really ever done, is what's called surveillance. So this is what people who are in health departments at local, federal, state levels do a lot of this kind of work. And this is a systematic approach to determine how many people have a disease, so that's the prevalence, or how many people develop the disease, or incidence. So as an example, so there was this study of a Zika outbreak on Yap Island, which is in a Pacific island, in 2009. It was published in 2009 in the New England Journal of Medicine, so if you want to pull this up. This got a lot of press over the last couple of years as Zika has spread more broadly. So they're looking at two aspects of surveillance. One was Zika antibody prevalence, and one was Zika disease incidence. So Yap has 1,200 a little, or almost 1,300 households. So it's a small island, and small population. That in a lot of ways makes it a lot easier to sort of get your arms around. So doing a study like this in Brazil is a lot harder than doing this in for in a lot of ways, because you're just being you sort of have exactly how many people live on Yap. That makes it a lot easier. So you have blood samples drawn. They sampled 200 households, got blood samples from people there, and then they interviewed people about disease with symptoms similar to Zika. So what they've done is they've come up with a sort of case definition, right? So it's their screening case definition. What they found, that of the 557 people who were sampled, 414 of them had anti-Zika IgM antibodies, right? So this is suggesting that the vast majority of people on this island had been exposed to Zika.
You said like they sampled 200?
200 households.
Okay, 200 households, obviously.
Multiple people per house. Other question? Yeah, that's a good point. And statistically, there are good reasons to do it. Statistically, it's a little iffy, but.
So was it like random sampling of those households?
Let's see. How exactly did they do this? Yes, it was a sort of pseudo-random sample. So if you think about how this would work, and there are these studies go on in the U.S. as well. If the CDC wants to do a study like this, they'll recruit a lot of times a bunch of MPH students, and they'll say, okay, come on, we're going to go to this neighborhood, and you're going to knock on every third door. So it's not exactly random, but it's sort of like that. Other questions? So, okay, so we see that the prevalence of exposure to Zika is very, very high in this population, right? Suggesting that that the transmission, at least in these settings, is quite high. But when you look at of the people who had evidence of having been exposed, 38% of them reported having symptoms. So that's suggesting that a lot of people are getting infected without actually getting disease. And you also see that of the people who didn't have antibody to Zika, 19% reported having symptoms that met their case definition. Any thoughts about why this might be happening?
Psychological.
So psychological, right? So people, if you ask people if they have symptoms, they tend to sometimes remember them.
The symptoms are not that distinctive.
Right. So the symptoms aren't particularly distinctive. So it's not a very, it's like, aches and pains and, there all kinds of things can cause aches and pains. Anything else?
Was that just the IgM antibody?
Yeah, so it's the IgM antibody. Could that be problematic?
So you had it a long time ago. Then you would anticipate the IgM antibody.
Right. So one is that, the people might have lost their IgM positivity if they had been infected a long time ago. They actually had a pretty good idea of when this outbreak started. It was a fairly contained outbreak, so that was a little less of a concern. But in general, if you were doing this, say, now in Brazil, that would be a bigger problem because the when exactly that started is a little unclear. You could have had people clear the IgM antibodies.
So actually, the negative antibodies population, did they live with those who have actually true the positive antibodies population? One is that if they're in the one family, actually one partner maybe really have the Zika disease. Another one is not have Zika disease. But they live together. Will the one who has disease influence another one, then she maybe have something?
Well, so, Zika is a virus, so it's transmissible, and, primarily transmissible by mosquitoes, but also through sexual contact, possibly other contact. So yes, I mean, you're certainly more likely to have, if your spouse or your child has Zika, that means that you're more likely to also have had Zika. The other thing to think about is these lab tests, right? So the lab tests are not infallible. There can be error on the part of the technicians that are doing this, right? So that there are only a few labs that can actually do this, and they are actually swamped because they do pretty much all of there's a lab at the CDC that did all of these assays. They do all of the yellow fever assays. They do all kinds of stuff. You think about, cold chain and shipping and just tracking all of these things. So these were shipped from YAP to CDC in Atlanta. So, all of these things can, lead to this 19%, right? So you always want to think about, in an epidemiologic study, how much do you trust your data? Where might problems be coming in, right? And all of these things are not that you shouldn't believe your data, but you should interrogate your data before you really sort of jump on to saying, oh, these 19%, maybe it's non-specific symptoms that that are resulting in this. Maybe it's lab error. Maybe it's clearing the IgM. Maybe somebody didn't develop an IgM response, some sort of immunocompromise. All of those things are possibilities. Okay, so this was a prevalence survey, right? They just went out over a period of, I don't remember exactly how long, but a couple weeks, said what percentage of this population have IgM antibodies, and of those, how many people have symptomatic or have reporting symptomatic disease. They also did an incidence surveillance study. So what they did was they went to the medical records of all the health facilities on YAP, and that, again, not a very big place. They have one hospital and 4 medical centers. And they came up with a suspected disease definition, right? So they've gone to all the medical records for a particular time period, and they pull out anybody who has a rash, arthritis or arthralgia, and conjunctivitis, right? So those 3 symptoms together are their case definition. And then they look to see if they can confirm that disease. And so the confirmed disease is going to be symptoms plus antibodies or RNA. And what they found was 185 potential cases. Of those, they have 49 where they are certain that it was Zika. So this is RNA or strong antibody evidence, right? So that antibodies are not a yes/no, there's sort of a range. And their antibody test wasn't particularly specific. So very strong response on the antibody test suggests it really is Zika. Weaker is maybe Zika, right? And maybe some sort of cross-reaction. So 59 probable Zika. So this is the symptomatic case definition plus a weak antibody evidence. 72 where they didn't have blood samples to test, and 5 where they tested negative. Right? So what do you think about their case definition?
What does no test mean?
It means that there essentially weren't stored blood samples in order to do the testing.
I mean, I guess it depends somewhat on how prevalent those 3 symptoms are in people that have Zika as well.
Mm-hmm. Right. So how prevalent are the symptoms, right? So if you only have one of the 3, you're not going to get picked up.
Right.
If you don't go and seek health care, you're not going to get picked up in this case, right? So you're probably getting the most severe symptomatic disease, right? So people who are just a little bit sick are probably just going to, either go on with their daily life or, stay home for a day and not necessarily go in to seek medical care. right? But most of these, of the people they were able to test, only 5 of them didn't have Zika, right? So it's probably fairly, that constellation of symptoms in a setting where you know there's an outbreak is a pretty good evidence that these people do have Zika. Okay, questions about this? So in this particular case, they already knew what was causing this disease, right? So they already knew that this was a virus. They knew that it was mosquito-borne. But this doesn't really tell you about what's causing the disease, right? It's just telling you that the disease is out there and how many people are getting it, right? So this is purely surveillance, right? And it's answering questions about how many and who. It doesn't really answer questions about why. So in this case, we know that Zika is caused by the Zika virus, but we don't really know why some people get sick and some people don't, right? So that's still something that's uncertain. The next sort of study design, in terms of making it a little more complicated, is at least design-wise complicated, not necessarily actually pulling off these studies can vary in terms of how complicated they are. So surveillance is not necessarily actually easy to pull off, even if it's a fairly simple and straightforward study. So for an ecologic study, we're looking at the correlation between rates of disease and rates and degrees of exposure, where we have both the exposure and the outcome measured on a population level. Right? So this is not really individual level data. This is sort of population. We're comparing different sort of segments of the population or different populations across space. So this is one of the sort of classic ecologic studies in cardiovascular disease. This is what's called the 7 countries study. What I didn't realize until I was putting together this lecture is this huge conspiracy theory around this study. So this was done in the 60s, and what they did was they got several countries, investigators from a number of different countries and regions within countries. They looked at essentially surveillance data, so how many CHD deaths are you getting per 100 people? And they looked at the percent of calories from saturated fatty acids. Okay? So they're not actually measuring this on an individual level. What they're using is essentially food disappearance data. So this is stuff that's calculated, that's tracked by agriculture ministries, right? So they, agriculture, USDA tracks, U.S. farmers, how much milk do they produce, how much is sold abroad, how much is, and from that you can say, okay, you've got this many calories from fat, you've got this many calories from protein from the milk, and add all that stuff up. So that is something that's done sort of population-wide. So what you can see is that each of these dots with a letter in it is a particular region across various countries. And you've got a really pretty broad range in terms of the percentage of saturated fatty acid, the percentage of calories from saturated fatty acids. So here, right, this one way out here is like 20, maybe 23% of calories from saturated fatty acids. This is East Finland. At the time, it was mostly the major industry was logging, and which is a very physically demanding job, right? It's not particularly mechanized at this point. And people, the typical lunch for the loggers in this area was bread with butter and cheese, right? So very high saturated fatty acid intake, very high death rate, right? And then you've got this W, right? This is West Finland. West Finland, instead of logging, what people are doing is fishing, right? So they're now eating, instead of a lot of dairy, they're eating a lot of fish. So the saturated fatty acids are a lot less, and death rates from coronary heart disease are also less. And then over here, you've got Greece, and so Crete, right? So the Mediterranean countries. So this is one of the first pieces of evidence suggesting that saturated fatty acids are a risk factor for coronary heart disease. A pretty strong correlation. So how is, in terms of strength of evidence that saturated fat causes heart disease? What do you think?
There could be a lot of other confounding factors that are not controlled for in this study. I mean, the geographic location is one of them, probably, and culture, so many things other than just the particular diet.
Right, so you don't really know what else is going on, right? So you've got everything from railroad workers in the US to, Belgrade facility, so I think that was like an institutional facility in Belgrade. So you've got, a lot of differences between these populations in addition to saturated fat. The other, so I've seen this where they also looked at same data, bathtubs per household, right? Or bathtubs, percentage of households that had indoor plumbing, and you see about the same correlation, right? So you don't, because you're not measuring individual level data, you have some problems with these studies. And like I said, there's a big online internet conspiracy. I was looking for a good graph. I found all sorts of stuff suggesting that the American Heart Association was in it with, I don't know exactly who, but to tell people that they shouldn't eat saturated fat. I don't actually think that's true. So ecologic studies can be done using existing data, right? So these sorts of studies, you're pulling data from health departments, from agriculture departments, so you can look at this in a fairly easy way, right? So if you're looking for sort of hypothesis generating, this can be really helpful, right? Because it's not like the saturated fat is based entirely on the study, right? There have been feeding studies, there's been a lot of other evidence that related to saturated fat. But as sort of a first step, this is kind of compelling. Why is it that Eastern Finland over here has so much higher rate of coronary heart disease than Western Finland? So it can be helpful for that perspective. But the problem is the ecological fallacy, right? So we've got both the confounding aspects, and then we also don't actually know, right? Since we're looking at population level exposure and population level event rates, we don't actually know if the people in Western Finland who are having the heart disease were actually the ones who are eating buttered cheese for lunch every day, right? That there was some range in there, and we don't have individual level exposures. So sort of another step up, so now we're talking about measuring more individual level exposure and outcome relationships. We can do cross-sectional studies. In a cross-sectional study, you recruit people, and you look at their outcome and their exposure at measured at the same point in time. Right? So we're looking at prevalent disease, remember, so we've got to have people who are who both got the disease and still have the disease, or still in your population, and prevalent exposure. Right? So you also, you don't know what their exposure was before they had the disease necessarily. So this is one of my studies looking at unrecognized MI. So a myocardial infarction. So not everybody who has a heart attack actually gets diagnosed with a heart attack. And it's actually about 1 in 5, maybe even higher, MIs are not clinically recognized. So if you're not clinically recognized as having had an MI, you don't necessarily get the second-year prevention therapy. So it would be great if we could come up with a way to screen people, right, and then get people who had these events, were not recognized, get them into treatment. So what we did was we looked at a population where we had about 30,000 people who had had electrocardiograms as part of a research study. We looked to see can we sort of pick out people who were likely to have had an unrecognized MI? So in the clinic, we could say, okay, these people should probably get an ECG when they go to see their primary care provider. So this is, age when you enrolled in the study, and this is looking at, did you have unrecognized MI versus no MI, and a couple of different characteristics. So we see that older people are more likely to have unrecognized MI. That's not surprising. They're also more likely to have a recognized MI. We know that age is a risk factor. We see that current smokers are more likely to have a recognized MI. People with diabetes, people with hypertension, both as people saying, yes, my doctor has told me I have high blood pressure, and then also looking at blood pressure as measured blood pressure. So for this particular study, we were looking at only characteristics that you would know in sort of a primary care setting, right? So we actually had a bunch of other information about these people, but we were only looking at, sort of from the perspective of, someone comes into a clinic, first time giving medical history, could the physician make a decision rule? So we see that, yes, we see these associations. They're more or less like what we would expect. Unfortunately, when we looked to see could we sort of put together a decision rule, it worked terribly. It worked not at all. And that is probably largely because of this cross-sectional study design. It was pretty simple logistically, right, because we just are looking at single time point, exposure, outcome right now. It was relatively fast because we didn't have to wait for events to occur. The issue here, and particularly with this study, is that prevalence is related both to incidence and duration of disease. And your disease may change your exposure, right? So in this case, the disease changing the exposure probably, the fact that someone has had an unrecognized MI probably isn't going to affect their smoking patterns, right? Because by definition, they don't know this has happened. It might affect their blood pressure, maybe. But in other cases, right, so if you say, you look at diet patterns in people with diabetes compared to people without diabetes, people who know they have diabetes, right? A lot of times we'll see that people with diabetes actually have better diets than people without. And it's not that, eating a lot of fruits and vegetables causes diabetes. It's that people with diabetes are counseled to eat a lot of fruits and vegetables, reduce their, processed carbohydrate intake, right? So you have this situation where the diagnosis is changing your exposure. In this particular case, one of the complications to being able to detect an unrecognized MI on electrocardiogram is first people have to have the disease, right? And they have to not only have MI, but they have to have an MI that causes a Q wave. Not all MIs do. They have to somehow not get diagnosed at the time, right? So sometimes people don't have symptoms. Sometimes people think that they are having something else, right? So you can have atypical symptoms. So you have to not get diagnosed. You have to survive your MI, right? So people who have MIs and then have a arrhythmic death immediately don't wind up in this pool. And then your Q wave has to persist. So similar to sort of the IgM story, these can resolve over time. And then you have to enroll in our study, and then you get diagnosed with unrecognized MI. So all of these things lead into getting to being a prevalent case, right? So that can make interpreting prevalence a little complicated because you have all of these things that have to happen in order to be prevalent. Yes?
I have a question more about the definition of a cross-sectional study because this is confusing in the past. So by definition, can you only have one time point in which you interact with the subject for it to be cross-sectional? So what if, for instance, you had follow-up with these patients? What would that design be?
Right. So the question is, can you only have one time point? And the answer is more or less yes, with some caveats, right? So, some of these, if you think about all these things that we measured, right? So this was actually measured on the whole total of this was actually measured on 2 visits because we had a telephone interview, right? And then some amount of time later, about 2 weeks later, someone went to these people's homes and did electrocardiograms, right? So there is some time frame there, but we're sort of considering that all as sort of a single time block. The question is, if you follow them up, is it then something else, right? And yes. So this study is actually the REGARD study, which some of you may have heard of. It's based here at UAB, 30,000 people. They've actually been following people for over 10 years now. And so that is a cohort study, which will be, I think, either the next study design or the one after that I'll talk about. One of the things that is a little bit tricky is, yes, the REGARD study. So the data set that I'm pulling this data from is in fact actually a cohort study because we've been following these people for 10 years since those in-home visits. But my analysis is cross-sectional. So, it's not always as definitive cut and dry. Does that answer your question?
It does. I guess it just gets a little, sometimes one can bleed into another type of study.
Yes. So, I'm sort of presenting these, and you see them in textbooks where they're presented as this is a case control study, this is a cross-sectional study, this is a cohort study. It's not always like a cut and dry, clear cut.
Right.
And you can have, a cohort study where here, something that is the underlying study is a prospective cohort, but I'm just using cross-sectional data from it. So I'm basically saying at the time when people enter the study. Other questions or thoughts?
The reason for the cross-section is you want to see both the prevalence and incidence at the same time.
Well, the reason for this was because the point of the study was to see if we could come up with a decision rule for who should get electrocardiogram screening. Is there some sort of subgroup of patients who, when they come in for their, cholesterol and blood pressure check, should we also just do an ECG at the same time? Right now, electrocardiograms are not recommended as a screening tool by any of the major recommending bodies. It's not that they're thought to be, well, there's just basically no evidence that they're effective. Clearly they can detect events that maybe we should be treating, but then you also have to balance that against, primary care physicians are doing a million different things. If they're doing the electrocardiogram on top of it for everybody, right, that's squeezing out other, so it's really sort of a balancing of resources and time. So that was why the cross-sectional design in this case.
The QA persistence in this was, how did you define that?
Oh, they just had to, so that was part of the problem, right? So we don't know, let's see. They just had to have, at the day when
So just a QA on that one study?
On that one electrocardiogram, on the day when they did their baseline, yeah.
So you're assuming it was persistent because it's still there?
Because it was there on the day that we showed up at their house, yeah. But we know that we probably missed people,
Sure,
right, who had unrecognized MIs who were just not picking up because they never had a QA where the QA was solved.
Was this study done prior to the 10-year cohort collection?
Yes. So there are now, so just recently they did a second in-home visit. So now we've got 10 years after the first one, we've got a second electrocardiogram. So now we can look at incidence of unrecognized MIs.
Because the second part of the question is if you follow them for 10 years and then effectively do this cross-sectional, is that really more or less like case control? Because now you effectively have 2 cohorts you're looking at, looking back to find the associations with certain.
So that would actually be a cohort study, right? Because you're not, case control studies, well, can I defer and then we can come back to that question?
Perfect.
Okay. Any other questions? Okay. So a cohort study, what we do is we identify a population at risk of disease of interest, right? So this is people who might develop your disease. And then we follow them up to see whether people with an exposure of interest are more likely to develop the disease or develop the disease more quickly. Right? So one of the things about this is that it has to be a population at risk, right? So if I was using that second electrocardiogram, right, I probably wouldn't want to include people who already had a Q wave at baseline, right? Because they're no longer at risk of developing the disease. They already have it. It depends a little bit on what your disease is, right? So if you were interested in, who's going to develop colds, you wouldn't necessarily exclude everyone who's ever had a cold, right? Because those things resolve. Having had a heart attack is different than having had a cold, right? That's a sort of, having had a heart attack is a permanent thing. Having had a cold goes away. Right? So you want to think about who's at risk of developing this disease. And then here we've got this time element, right? So we are looking at, rather than sort of saying exposure and outcome now, we're saying exposure now, outcome later. Okay. So this, so here, example here, this is the health professionals follow-up study. These are almost 40,000 men who have been followed since 1986. This study is still ongoing. So in 1986, they filled out a questionnaire about drinking. Every 2 years for 12 years at this point, but far longer now. Participants were sent questionnaires. Have you ever had a heart attack? And that was the outcome of interest, and they asked about dates. They went after medical records. And if people don't respond to this questionnaire, they'll start looking to see if the people have died in the interim. So one of the tricks to the study is, asking these questions for the general population is pretty difficult to, heart attacks, people more or less can report. A lot of other outcomes are iffier. So they recruited people who would know, right? So this study is dentists and physical therapists and other men in the medical field because they thought that they would be able to accurately answer these questions. They've also done things like sent people their own blood draw kits and had them send them back. So they've been able to really make use of the fact that this is people in the medical field, so they could just go and have somebody in their office draw the blood for them. And so it can do this whole thing through the mail. So for this particular analysis, what they did was they looked at rates of heart disease compared by alcohol drinking versus not, and then types of alcoholic beverages. So here, you can see the relative risk of MI. So relative risk, this is a ratio measure. So which means that a ratio of one of the same number to itself is 1. Right? So the null value here is 1. This means no association. So the reference here is no alcohol per day. This is like a little less than 1 drink per day, about a drink, about 2, or 2 or more, and then heavy drinking. Okay. And each of these different symbols is a different kind of alcohol. One of the things that you hear in the press a lot is that red wine is better for you than other types because of stuff in the red wine or resveratrol or other things. When you look at this, it doesn't really look very different, right? It looks like the rate of MI is lower the more you drink, up to a certain point, probably, and it doesn't really matter whether it's beer, liquor, or wine. Thoughts about this?
Red wine look like it looks pretty high there. I'm just confused about this.
So why this bump up?
Yeah, why so different?
So the question is it really different, right? So it's a little hard to see, but you've got the confidence bounds, right? So the dots are the in this case it's hazard ratios or relative risk. And then you've got the whiskers, which are the confidence bounds, right? So the confidence bounds are pretty wide here, right? So this is telling you essentially how much information do you have about where this dot should sit.
So the lower confidence bound for the red one is all the way down there.
It
Looks like below the liquor.
Yeah.
Okay.
Yeah. So this is sort of a data presentation issue, right? So a lot of times, like, you might want to spread these out a little bit so that you can actually see which confidence bounds are there, and so they're not all sort of on top of each other.
So actually from biological point, this finding cannot explain what means that cannot explain from the logical point or biological point. It cannot explain why the more alcohol or liquor in gym, the lower risk CHD you will have. So.
Right. So I think sort of going along with the idea of, saying that there's no biological explanation here as to why we're seeing this, right? So kind of going along with the team science theme, there are very few cases where, as an epidemiologist, I would believe a conclusion, like I would firmly believe a conclusion based solely on an epidemiologic study. There are a few, right? There are, things like Zika, right? So Zika and the microcephaly, that is pretty strong evidence just based on, without having, animal models or other things. Because there's such a strong association, because there's sort of a plausible reason. There's actually these criteria that you can go through to sort of think, that help you think through, is this cause and effect? This is not enough cause and effect, right? For at least not for me, and I actually think these results are probably pretty close, reasonably close to right. But when you do feeding studies with alcohol, right, so you control people's alcohol intake and their other intake, you see that their HDL goes up. You have alcohol can influence people's clotting factors and other things that could affect MI. Both basic science and sort of clinical studies suggest that this might be real. With the caveat that people lie particularly about how much alcohol they drink, particularly if they're drinking a lot of alcohol. Right? We know that very, very high alcohol intake is cardiotoxic. Probably we don't have a lot of people who are drinking, this is like 50 grams per day is actually pretty high alcohol intake. That's probably most of a bottle of wine every day. And we are, this study has recruited men who are employed in the health field, so, we're not getting people who are, alcoholics to the point where they're not functioning, and people who are sort of functioning alcoholics are probably not telling us the truth. So, I think that if we looked out even further, you'd see probably an uptick in heart disease. So, right, so I think that interpreting these results have to be interpreted in the context of other things we know. Other questions or thoughts?
And so was this control for, like, how many, for instance, how many people took in 50 grams a day versus, I'm just curious about how that works.
So it doesn't control for the number of, so essentially.
That's what I'm saying, like, if only 100 people at the study drink 50 grams a day, but none of them had heart attacks, well, right, compared to if everybody drinks 20 glasses of wine.
So you wouldn't, you don't necessarily control for that in the sense of, including it as a variable in the model. Where you see that come in is actually in the width of these confidence intervals. Because that tells you, you can see that here you have a lot of people who are drinking very lightly, which means that you've got these are very tight, which means you've got a lot of information here. Here you've got, these confidence bounds are broader, and that is because you just don't have that many people.
Okay. Actually, what is the duration for the follow-up?
12 years in this analysis.
Okay, I'm concerned that maybe those who drink more, maybe those are more healthier, and then those who drink less, or maybe more unhealthy, less healthier, so they drink less alcohol, and then actually they may be at baseline, they may be actually at higher risk for developing CSG, so they maybe know that maybe drink less alcohol will be beneficial for them, and then those healthier know that maybe more younger or at least male, so they will drink more alcohol, but then alcohol, because they are young and healthy, alcohol has no effect on them.
Right. So the question is, people maybe know that they're less healthy, so they're going to drink less. And so there's a couple of things that have been done here. So one is these are actually modeled, so they've attempted to control for age, for baseline health status. The other thing is that there have been sensitivity analyses that they've done here where they actually excluded people who used to drink and no longer do. So people who quit for some reason, might be different from people who just never really drank. So those lends a little more confidence to these estimates. So one of the great things about cohort studies is, unlike the cross-sectional study, we've now got temporal ordering. So we know that our exposure happened first, right? So that helps. That's always a good thing. When we're talking about did one thing cause another, knowing that your exposure preceded your outcome, that gives you some confidence. We're looking at incident disease, right? So we don't have people who already had a heart attack. That also can lead to the problems you were mentioning about less healthy people having different exposure than more healthy people. The thing is, though, right, you had to enroll people, and that doesn't happen in a day, right? That happens over the course of, essentially the whole course of 1986. That was when they rolled out, and it took a year just to get people into the study. And then they spent 12 years sort of ghoulishly as an epidemiologist waiting for these events to happen, right? You're, as someone in public health, you don't want people to get sick, but you kind of have to wait for all of your events to occur, so you're sort of sitting there waiting to see, in order to be able to do this analysis. And heart attacks are unfortunately relatively common, getting less so. But the less common the disease, the more people and the longer time it's going to take to be able to collect your data to do the analysis. Questions about this? So if you're looking at a rare cancer, you're waiting a very long time with a very big population. So one of the ways that we will try and avoid that is what's called a case control study. So with a case control study, instead of sort of enrolling people who are at risk of the disease, what you're going to do is you're going to go out and find people who have the disease that you're interested in, and then you're going to identify a control group without that disease, right? And you're going to compare their exposure history. So this is, this can get around the problem of the time that it takes and the number of people it might take in order to get enough cases of the disease, because you're going out and selecting cases. So in this case, this example, we've got 377 mother-infant pairs where the infant had persistent pulmonary hypertension of the newborn, PPHN, Right, so this is a problem where the infant circulation essentially is not adjusting properly to being outside of the womb. And then you've got 836 mother-infant pairs without PPHN, and they interviewed mothers about exposure to antidepressants, so SSRIs during pregnancy. And they want to know, are mothers who take SSRIs during pregnancy more likely to have infants with PPHN? Right? So you go out, find these infants. These are from big consortia studies, right? This is luckily not a particularly common problem. So you've got, I think it was maybe 30 regions, so not just hospitals, but 30 regions across the U.S. Where you're identifying cases and then identifying mother-infant pair controls from those same regions. And then do the interviews with the mothers. So what do you think about the way you're identifying exposure here?
The problem with that one is recall bias. How people are going to remember. And there are some studies, if you ask, let's say, breast cancer women about their diet, like whether it was high-fat diet, if they had the breast cancer, they would say, yes, we did. But the earlier, actually, surveys from the same people showed that actually they didn't say that earlier. But after they got the breast cancer, they started remembering that, yeah, they were eating a lot of fat. Similarly, mothers may say things for those 377 infants that really may not be the case. Maybe they didn't even take the medication. They may just confuse.
Right. So, yeah.
They control for gestational age.
Yes, they did.
Or at least have some matching.
And then the definition of exposures, did they, take it 2 days out of their pregnancy, or did they take it their whole pregnancy? What dose of medication were they on? Which SSRI were they on?
Right. So you've got a couple of issues here, right? So you've got the issue that in order to collect your exposure information, you're relying on women recalling what they did while they were pregnant. And in a particular concern is that the women, infants who are hospitalized with a serious problem may recall things differently than women whose infants are healthy, right? So that's one concern. You've got issues of, the sort of intensity of how long were they exposed, what SSRIs are broad, but they actually did, and don't have the data here. This study, they did actually ask which specific ones people were on and how long they took them. They also asked them about whether they were, about timing, right? So that is actually, the timing piece is actually kind of nice, because here's the data, right? So you've got data about were they taking them never, before week 20, or after week 20. And so these are mutually exclusive, so if people only took them early in pregnancy, they're here. If they took them all through their pregnancy, they're in after week 20. And so one of the things that the authors of the study said was, well, probably women aren't thinking about necessarily when in gestation that these drugs might have caused problems. There are reasons to think that it might just be sort of later in pregnancy. So that the fact that you don't really see an association here with the early pregnant, people just taking the drugs in early pregnancy, and you only see it really with the later pregnancy, suggests that maybe recall bias is not fully, at least not fully explaining this.
What about a person, like the difference between those two types of people, why would a person take those medications? I mean, there's an inherent difference in those two groups. How did they show more that?
So any ideas of how you might, right, so women are taking SSRIs usually because of depression, not always, but usually. So any thoughts about how you might try and address that issue?
Well, you have an abundance of people you can potentially match with the small cohort that actually have children with the systemic medication. So you could potentially choose matched controls that match them in this aspect.
Match them by saying that,
Maybe.
finding that they take those medications before the pregnancy, but they stop after they.
Or, you know, you determine why they're taking it. If it's depression, you can match them with a mother that also has depression that perhaps stopped taking their SSRI or took a different type of antidepressant.
Right, so you can match on, you know, essentially indication for the SSRIs. They were not able to do that in this particular study because because again, you've got this recall bias issue, you know, and it's a little hard to say, you know, were you depressed? Yeah, so that they weren't able to do that here. But they did, you know, if you pull up this paper, you'll see that they actually did look at associations of other antidepressants. There weren't really any associations of other antidepressants with this condition, suggesting that it might be the SSRIs and not depression per se. There have been other studies where they have been able to match different study designs where you're looking at administrative data. So they essentially limited their study population just to women being treated for depression and looked at whether in that subgroup SSRIs are associated with PPHN. But yes, that's definitely an issue, right? That you want to know that women who are using SSRIs are likely different in a bunch of different ways from women who aren't, and that not just that SSRI exposure. Other thoughts or questions about this? Right, so this is efficient when the outcome is rare. So in order to do this study as a prospective cohort, you'd have to enroll women maybe early in pregnancy, and you'd have to enroll a lot of women because luckily PPHN is not something that happens to most infants, right? And you'd have to follow them up. It would be pretty difficult. So, you know, this is studies that have done that where they, when they've enrolled women, what they're actually doing is they're looking at administrative records. So they'll go to one of the Scandinavian countries where there's very good data on everybody, and pretty much everyone is getting prenatal care. So you've got, you know, a big population of women, pregnant women, that you're not actually spending money on because this data is being collected as part of their routine care. Then you don't have as much granular data, but you know, then so to do this study in the U.S. would be difficult. It's yes, yes. It has been done in women on Medicaid, actually in the U.S. But you know, here they were able to actually do medical record reviews, so they know that these babies really did have PPHN, and so they, you know, they have more detailed data there. But you've got this issue of the exposure measured after the outcome, and the outcome can change the exposure or that report of the exposure. So they've done in this study, you know, it was in the New England Journal. It was a very well done study, and so they've done a bunch of things like looking at the timing, like looking at other antidepressants to try and get around this issue of recall bias. So those are the basic types of study designs. Like I mentioned before, it's not always cut and dry. You know, there's some bleed over, some other sorts of variations on these study designs. Those are sort of the basic ones that you might consider. Questions? Thoughts?
Going back to the initial, the undiagnosed microinfarction. So if you basically come up with that group and then you have another group that does not, so you have a control and looking back at those exposures, that seems to be, would that be a case control?
So I think, if we're talking about the regard studies, we have, in 2003 to 2007, which is when these people are enrolled, we have one ECG. We take the people who have ECGs that are clear, and then at 10 years, are there Q waves? I would call that a cohort study, right? Because we've enrolled people who are at risk of the disease, and we followed them forward.
Okay.
To get a little complicated, we could, and we sometimes do this, is say, okay, so now we've got people at 10 years, and we know, this group had unrecognized MI, this group did not. And it's not an exposure that we actually measured already. We can do what's called a nested case control study. So we can then take our cases from a defined population. That's why it's called nested, because we have a defined cohort that we know, we've sort of enumerated everybody who's in that cohort. And then we can identify controls and say go back and measure a biomarker or some sort of genetic marker in our stored blood samples. And that would be a case control study. But if we're just looking at who developed the outcome, and we have essentially everybody, both information on exposure in everybody, both the cases and the non-cases, then that would be a cohort. Does that answer your question?
It does.
Okay.
It does, and it seems like the study design, the regard studies, it's a prospective observational studies, what it sounds like, and you're kind of finding these associations.
Yes.
And then taking that data, and if you want to look at perhaps comparing it to a different group, for instance, some other control, that would be called nested case control in that standpoint. So that's helpful to.
Right. So the case control, you're essentially you're usually doing some sort of sampling. So in the regard study, the ECGs, I think, are just being read now for the second visit. So, if we pulled the unrecognized MI cases from that group and then compared them to everybody who didn't have the event, that would be essentially a cohort. If we, for reasons of expense, generally only compared them to a sample of the non-cases, that would be case control. Or if we're comparing them outside. Comparing to outside populations, you can do it. It's a little tricky because you have to think about how do people get into your study, and are there differences between the people who got into the case group and people who got into the control group. And that's called selection bias. Other thoughts or questions? So, as I mentioned, this is a whirlwind tour through epidemiology. So the next topic is correlation and causation. And we've talked about this somewhat, but you'll hear a lot that correlation does not equal causation. So why is correlation not causation?
Could have several causes.
Right. So you could have several causes. You could have several causes and have it not be biased necessarily, but you don't necessarily know that what you're seeing is really a cause-effect relationship. And there are a variety of kinds of biases that we talk about. So one of the big ones that we worry about as epidemiologists is confounding. We also have issues of measurement error, right? So lab tests are imperfect. If you're relying on self-report, people either intentionally or unintentionally don't necessarily always tell you the right answer. You can have selection biases, and this is the case where, maybe a lot of times if you're doing a case control study, all of the people who you ask who have the condition say, oh yeah, I want to participate. They're more motivated. And maybe 20% of the people who don't have the condition that you're interested in say yes, right? So then you start worrying about, okay, these people are systematically different in ways other than just their disease and their exposure, right? And other types of bias. So, you know, there are different sorts of fields in terms of, or different approaches in terms of how you label and name these sorts of biases. My training is that you sort of lump them and think about, you know, how that you'll sometimes hear, you know, different people will have named biases, and there are different ways of describing it. But they, from my perspective, they all kind of, most of them fit into founding, measurement, error, or selection bias. It's not necessarily the right perspective. When we think about confounding, the basic sort of underlying problem is that people who are exposed are different than people who are not. Or another way of saying this is that the risk is different in the exposed and unexposed groups in ways that are not related to that exposure. So if we're interested in the association between race, ethnicity, and obesity, right, so in the US, minority populations tend to be more likely to be obese than non-minority populations. Part of what we might be seeing is actually an effect of age. So people tend to gain weight as they age, and minority populations, you know, just the demographics are somewhat different than non-minority populations. Right, so some proportion of the association between race, ethnicity, and obesity is actually due to age and not to race, ethnicity. And this is the sort of diagram that we use when we start thinking about is something a confounder, right? So we're really interested in this race, ethnicity, obesity association, and age is sort of a nuisance factor here, or a confounder here. So what might be a solution to this?
Control for age.
Yeah, you control for age, right? So that's pretty straightforward. There's a bunch of different statistical techniques to do this. I think David Redden will be talking about some of them. We control for age, right? There's a bunch of different ways to do this. Pretty easy. Okay, so if we're looking at fruit intake and obesity, right? People who eat a lot of fruit tend to be, you know, be healthier than people who don't eat a lot of fruit, right? Right, so now we're seeing that some of this fruit intake obesity association is due to this propensity to be healthy. People are doing a bunch of different things. How do we measure propensity to be healthy?
Regular exercising. I don't know, reading magazines about
Right, so we can generally measure age pretty well. Even age is not 100%, but we do a pretty good job. We can get at some aspects of propensity to be healthy, so we can ask people, you know, not only are we asking them about their fruit intake, we can ask them how often do you go to the gym, right? How often do you walk? How often do you read magazines about health? You can ask them, you know, sort of psychological scales about propensity, you know, how much they value being healthy. But this thing is a little harder to measure, right? So even if we include all those variables, it's a little harder to get your hands around than something like age, where we at least have a pretty good idea of how old people are, right? So how do we measure healthy, right? So this is something where you've got these variables that are a little more nebulous, or that for whatever reason you didn't measure in your study, and so they're still there, right? And you can partially control for them by doing things like adjusting for exercise, adjusting for some of these other characteristics. But you're still kind of worried that there's what's called residual confounding left over, by these things that are a little harder to get your arms around. And then we have a lot of times where just because you can draw a picture like this, it doesn't mean it's confounding. So we're interested in the association between obesity and myocardial infarction, right? We know that obesity causes type 2 diabetes. We know that type 2 diabetes is a risk factor for myocardial infarction. But diabetes here is on the causal pathway, right? Obesity is coming first. So do we want to adjust out that effect of diabetes?
What's the correlation between diabetes and obesity?
Hi.
You build them both into your model.
So you can build them both into your model. The thing is though, right, so if we're just looking at obesity per se, right, we don't want to actually adjust for things that are in the causal path, right? So because now you're sort of taking away the ways in which it's working, right? And you can think about, there would be other things in here. You could look at, inflammation and other things that are caused by obesity and the causal pathway. Sometimes you do want to adjust for it, or you want to see like, okay, people who are obese with diabetes, people who are obese without diabetes, people who are non-obese with and without diabetes. And so you can, have that instead of having essentially a one-dimensional exposure, now you've got a two-dimensional exposure. And so that is certainly an appropriate way of handling it. And sometimes you want to say, do what's called a deviation analysis, where you want to say how much of this association is due to diabetes. But I can guarantee you that if you use some sort of automated variable selection model, diabetes is going to show up in it, right? So you need to think about essentially what is the pathway, right? And you don't want to just like let SAS or Stata or some statistical program pick your model variables unsupervised, right? Because it's going to pick this variable because we know that this is in the causal pathway. That make sense? Okay. So what if you don't know? Right? So here, like this example, like pretty sure that obesity precedes is a cause of diabetes, that diabetes is a cause of MI. But it's not always that clear, right? And if you're measuring these two things at the same time, you don't have the temporal ordering. So what do you do?
Well, I mean, don't you pick, like, in this you would just say, okay, let's just look at obesity and MI. Mm-hmm. And then just do subgroup analysis of obesity with diabetes at the same time.
Right. So you could do that here, but here, we're pretty certain that this is that the arrow goes this way, right? What if we're uncertain and we think the arrow might go that way?
Some studies will do univariate analysis and then use logistic regression and build the assess.
Yeah, so you can do that. So one of the things that when you do, you want to think about, is this a confounder or is this an intermediate? So in this case, diabetes would be an intermediate association between obesity and MI, whereas obesity would potentially be a confounder of the association between diabetes and MI. When you build models, you're actually building in assumptions about which direction these arrows go. So you want to make sure you think through those assumptions. And a lot of times, in this case, I wouldn't, if I was doing a variable selection procedure and I wanted to look at obesity and MI, I wouldn't even give my statistical software the option of picking diabetes because it's in the causal pathway. So, I think that you need to think through, sort of, is it a confounder, is it in the causal pathway? If you don't know, you need to make your best guess. Questions? So, this is something we spend a lot of time thinking about, about sort of these kinds of diagrams, which direction are things going. We spend a lot of time doing statistical modeling to try and handle these kinds of biases. So this is, in any sort of observational research, this is confounding selection bias. These are big topics, not just epidemiology.
So when people write up a study like this and they had to make best guesses, how do they describe the best guess in the way they write the paper so that you can understand where the weaknesses might be for the reader?
Right. So how do you describe it? Generally speaking, I would say you would talk about, okay, so my main model, usually what I'll do is my primary results, right, are things that I'm pretty certain are confounders. And so I will talk about, okay, in this model, we adjusted for things that we thought were confounders based on prior literature and associations in our data, and list out, age, sex, race, region. Those sort of always go in there. And then, if I'm talking about this, I would also probably include physical activity. I would talk about, maybe dietary factors, other sorts of health behaviors. And then I would say, okay, so now I've got this model. And then I would say, well, and then there are these things that I'm not sure if they're sort of preceding my exposure or coming after my exposure. So I might do a second model that would include those and say, these may be mediators or confounders of the association, and look at it that way. Other thoughts or questions? In general, if you are adjusting for things that you think might be mediators, most of the time that's going to make your association smaller. It's going to take away part of that association. So when we think about developing a testable hypothesis, so my postdoc, I've mostly worked on diet and heart failure. So we want to know sort of broadly, does diet affect heart failure? This is not a testable question, right? Because what aspects of diet, right? Are we talking about specific foods and nutrients, diet patterns? Are we talking about deficiencies, nutrient overload? How? Are we going to talk about preventing heart failure, slowing progression, preventing mortality, reducing symptoms, right? These are all sort of different ways of assessing what your outcome is. Who are we talking about? We're talking about older people, women, men, people with diabetes, mice, right? Not necessarily going to have the same exposures might not have the same effects in women and men, in mice and people, right? We've got a bunch of different ways of doing this. So if you think about what makes a good research question, you're talking about a question where your research question has to be fairly detailed. There are these two sort of framing criteria that can help with this, and this article here, for whatever reason, there's a really nice article in Canadian Journal of Anesthesiology, but it's pretty general, so it's not specific to anesthesiology. And they didn't come up with these criteria, but they do a nice job of describing them. So FINDER stands for feasible, interesting, novel, ethical, and relevant. So are these absolute criteria? Or no, right? So something that's feasible for me is not necessarily going to be feasible for a fellow, and something that is feasible for George and Virginia Howard, who are the PIs of the REGARD study, I could never pull that off. I just don't have the logistical ability to recruit 30,000 people and maintain this big team over decades. So that is sort of thinking about, for your purposes, is this feasible? Is it interesting? Right? You don't want to do something that you think is boring. No, you should talk to people around you, both sort of in your research group, but then also external to your research group, external to your field. And that helps you evaluate, is this broadly interesting? Novel, again, you don't want to do the same, sort of like bang on the same topic over and over and over, but rarely are we sort of coming across brand new ground. ethical, always important to be ethical. You certainly don't want to do anything unethical, but it's not always a straightforward question. So, it's there's a lot of sort of judgment involved in deciding whether a study is ethical or not. So, for example, there's a study that was incredibly interesting and incredibly valuable data. I can't believe they got this past the Institutional Review Board, where they took men who had had heart attacks. They had them exercise on exercise bikes while with a ECG on, while breathing diesel exhaust. And they showed that breathing diesel exhaust compared to not breathing diesel exhaust increases the ischemia, right, as measured by these electrocardiogram measures. I can't believe they found people who were willing to do that and that it was approved, but they were able to do it in a way, I guess, that they thought was safe enough and not, they didn't have any adverse events, so it seems like nobody was permanently harmed by this. But I'd be a little nervous doing that study. Thanks. And relevant, right? So you don't want to do something that is not going to be informative. In cardiovascular epidemiology, one of the challenges is that a lot of our studies were done, were started 30, 40 years ago. In a lot of ways, that's great because we've been following these people for a long time. But in a lot of ways, it's kind of problematic because the rates of heart disease have gone way, way down, right? So talking about what was happening in the 70s and 80s is maybe not as relevant today, and the way that we treat cardiovascular disease has changed dramatically. So, are the findings from, the 1970s and 80s really accurate and relevant to the clinical practice today? Okay, so those are some issues to think about. And then in terms of framing your hypothesis, there's the PICO approach. So again, this is an acronym. So patient population of interest. What is your intervention or issue or exposure of interest? Comparison. Who are you comparing this to? What is your outcome? And your time frame. So time frame is a little surprising. And so, so initially it didn't have this T on it. But it's really important to think about time. And my silly example here is rabies is an infection associated with a higher risk of death. Yes, right? Of course. Except, it depends on when we look, right? So if we have people who are infected with rabies in this red line, right? So this is their risk of death, goes from 0 to 1, right? It's risk in proportion. People who are infected are likely to die really soon, right? People who aren't infected, though, are also all going to die, right? So if we're looking here, right, in the year of rabies infection, you have some people who aren't rabies infected who are going to die. You have almost everybody who is infected with rabies is going to die, right? So you have a huge relative risk here. We're looking 100 years from now, right? None of us are going to be alive 100 years from now. So it doesn't matter whether you were infected with rabies or not. So the time matters. Questions?
At 50 years, and it tells you a lot of people die for other reasons other than.
Right. Right. So people are dying for other reasons, right? So, that's not saying that rabies doesn't cause death, just that the shape of these curves matters, right? And when you take your slice is going to affect how your relative risk.
So everybody's dead at 1 on that graph?
Everyone's dead at 1. Yeah, that's 100% death rate. Right, and this isn't data. This is just a drawing.
Right. Yeah. Some people survive rabies.
Yeah, some people survive rabies. Not a ton, but some do. So, okay, so here's a better research question. So is intake of fatty fish associated with risk of hospitalization or death from heart failure among women? Right, so this is a little more specific. This is not quite enough, right? So it's a little hard to get all of these things into a single sentence when you're doing a hypothesis or a research question, but here's something that's a little more concrete, right? So this is something we can actually answer a question. So we're talking about fatty fish. In particular, we're talking about salmon, herring, and mackerel. So this is Sweden, so people eat mackerel and herring. People don't really eat mackerel and herring so much in the U.S. We've got 9 years of follow-up, so here's our time. We have women who are middle-aged and older, living in 2 counties in central Sweden. And we're only looking at their first heart failure event, right? So we're looking at developing incident heart failure. We're not looking at, what happens when people have heart failure or symptoms of heart failure. We're just looking at time to your first heart failure event. So in this study, we found, okay, so again, this is a relative risk graph. People were comparing women who never ate fatty fish to people who had it less than once a week, 2 times a week, and 3 or more times a week. So this sort of gets to your question about how many people. So one of the challenges of doing research in Sweden is that it's a pretty homogeneous population, particularly in these 2 counties. So this is not Stockholm. Stockholm's fairly diverse, but these 2 counties are pretty much like all Swedish people, and pretty much everyone eating fatty fish once or twice a week. We get very few people who are eating it 3 or more times a week, and those people are usually eating pickled herring and drinking a lot, so it's maybe a little bit different than having salmon or herring for dinner. So we tried to adjust for that. So one of the things that was very important to adjust for here was alcohol and binge drinking. So, anybody want to volunteer their disease area of interest? Anyone working on designing a sort of population study?
I do concussion work.
Okay.
Yeah.
So are you looking at outcomes in people with concussions, or?
Correct.
Okay, so outcomes in people with concussions. So what kind of outcome would you use?
So we're looking at these little imaging predictors on post-concussive MRI.
Okay.
And using that to see if it correlates with symptom duration or severity.
Okay, so you're looking at concussion symptoms, right? Sort of post-concussion, like long-term concussion symptoms?
Like just up to 30 days after. Yeah.
Okay. So like not the immediate, so like 30, like...
Well, we're doing an MRI right after, in 24 hours, and then seeing if what we see on that, does that correlate with symptom duration. Okay.
So you're saying, are people having symptoms essentially at 30 days, still having symptoms at 30 days? Okay, so that would be your outcome, right? And so your sort of exposure, so not intervention here, this is more developed people doing clinical trials, but here so your MRI predictors at 24 hours you're going to be your essentially exposure here.
Right.
So, okay, so you've got, how are you measuring your outcomes?
So for imaging, we're doing 2 variables, FA and fractional anisotropy and median diffusivity.
Okay.
On MRI, yeah.
So those are your MRI exposures, right?
Right. And we're comparing it to a baseline MRI as well.
And symptoms, how are you measuring those?
We do a post-concussive symptom questionnaire.
So it's
at 24 hours, 14 and 30 days.
So it's self-report symptoms? Yeah. So you've got some sort of standardized questionnaire?
Yeah, it's a standardized.
Okay. And so then you've got these MRI measures are your exposure. So that would be your, and there's, I'm sure, a lot of technical details that go into doing the MRI and then
Right.
evaluating the sort of raw data that come out of the
There's a
MRI.
lot of things that we're doing to try to figure out where to look. It's complicated, but.
Yeah. And so, if you're writing the paper, all of those things go into sort of your exposure definition, right? So who are you comparing?
So this is kind of getting a little tricky, but we're thinking about comparing the post-concussive group to a group of healthy age-matched controls from a database.
So you've got these MRI measures. Are you comparing?
Well, actually, we're comparing it to their own baseline scans in some instances.
Okay.
So, we can go back and look at this area versus post-concussive area and see if there's changes in this area.
So sorry.
Yeah.
This is the sort of thing.
I just submitted a grant, so I'm still confused.
Yeah, so this is as sort of when I'm collaborating with people as an epidemiologist, sort of statistician, these are the questions that I would run through, sort of, so I apologize for putting you on the...
That's fine.
So you have, and here it sounds like you've got a couple of different comparator groups, right? So you've got different regions within the brain, potentially. You've got people with and without concussion, and then you've got people with concussion at different time points, right? So I think that all of those are answering potentially slightly different questions. So one of the things that helps when you're sort of building a statistical model is to think about, okay, which of my many related questions am I answering with this particular statistical analysis? And that's one of the things that can be challenging to do because you sort of have, you certainly never want to lose sight of the broad picture, but your stats are not broad picture, right? The stats part are very narrowly defined questions that sort of feed into this bigger picture. So your patient population sounds like people with recent concussions?
So we're just doing football players, current collegiate football players, and then there's they just have to be greater than 18. But the other criteria is they can't have a concussion within 60 days of the baseline scan. But it's very small.
Okay, so this isn't just like everybody. This is
Yeah,
football players.
Just football players.
Okay.
Because we're trying to get pre and post scans basically.
Mm-hmm.
That hasn't been done.
Right. So that's one of the benefits of doing a narrowly defined population is you can do things like, okay, we suspect that this person has a very high risk of developing a concussion.
Right,
sometimes.
and we're only doing skill players. Hopefully, they have a higher risk amongst the whole team. Basically, we know from prior literature, so yeah. Even smaller.
Okay, so yes, you've got a very specific patient population here that you're examining. What are skill players?
Wide receivers, D-backs, quarterbacks, linebackers. Not offensive linemen, basically.
Okay. Right. So you have so I think your study is great because you have a very specific patient population. So that is helpful, right? So you don't have a sort of nebulous patient population, which can be a major problem. If we're talking about middle-aged and older women, right? That's a really broad range. Here you've got very homogeneous population in terms of who these people are, in terms of age range, in terms of their risk of developing the disease, and presumably they're all very healthy if they're collegiate football players. And so time frame said 30 days.
So beginning of the season they do a baseline scan, and then if they have a concussion, we do one in 24 hours and another one at 30 days.
So when you're doing this study, what are the things that you might think would be important confounders, right? So these are going to be things that are strongly associated with outcome and exposure in general. So what other stuff are you measuring that you think might be important here?
So what are some potential confounders? Is that what you're saying? Or?
Yeah.
Yeah, I mean, race maybe. Things that we're not going to look at is like neck size, certain intracranial things that may play a part, you know, that we don't have in the body of the study, but could be looked at. You know, there's a lot of things like that that can play into it.
Mm-hmm. Yeah, I mean, you know, the more heterogeneous your population is, or the more worried you are about confounding.
Right.
Here, it sounds like there's some sort of physiologic things, some demographics maybe. Are you measuring anything about like history of concussion or?
So, no, we're not thinking about that.
Other than they can't have had a
Right,
concussion.
because I mean, again, it takes away from the baseline scan if we have to go back and compare all that to their history. And plus, again, being diagnosed with a concussion and having a concussion, again, are so subjective now that it's kind of hard to do that reliably. So that was one of the issues. Have you ever had a concussion in your life? A lot of people would say no, but there's no real objective definition, step by step.
And you know,
but yes, we'll be asked about that.
so that is, you know, you might not be super worried about, particularly if you're doing within person comparisons, right? So that's one of the, that's like that's an extreme form of matching, right? If you're looking at within person, you're controlling, you know, people's neck size is not going to change that much over the course of a season, right? People's, you know, demographics don't really change over, and health status usually are not going to change that much over the course of a season. So, you know, that way, when you do the within person, that can help you deal with a lot of confounding. Yeah. So, you know, if you're thinking about study design, right, so it sounds like, you know, this is a frequent outcome, fairly frequent in this population, not everybody, but you're going to get a decent number of people you expect. You are, right, so here you've got exposure measured both before and after the outcome. Sometimes, you know, if you're talking about genetic exposures, right, so generally speaking, your genes aren't going to change very much, whether or not you have a disease. It's not always true, right, so if you're looking at epigenetic changes, so sort of things like modifications to the genome, that your disease state can affect that. Does prevalence tell you about incidence? Right? So this is a question of, can you measure essentially your exposure and your outcome at the same time? Right? So you've got a prospective study because it sounds like, you know, you can't really measure, do you have a concussion? Yes, no, and, you know, are these exposures, right? So you've got some time built in here. And then how much time and money do you have, right? So those are, time and money, unfortunately, are important considerations when you're doing science, right? So you might want to do a cohort study, but, you know, if you have to wait 20 years, right, you don't want to just be sitting around for 20 years. That's not very good for your career, right? So you want to do something, you need to do something in the meantime. And so all of these things are going to feed into which study design you do. And in the last few minutes, so epidemiology is a big field. It tends to be, you know, fairly complicated. There's some, both in terms of theory and then how you actually pull this off. These two textbooks are good. I really like Epidemiology and Introduction because I think it's very readable. This one is free online, so that makes it very good as well. And it is a good textbook in general, but free online is always nice. This is the paper that I talked about with the Feiner and Pico criteria. This is a guideline. It's not quite as strict or developed as something like the Consort guideline for clinical trials, but it really goes through what you should be reporting when you do an observational study. And when you think about what you need to report, you think about, okay, how do I, you know, thinking backwards can help. You need to have a sample set, like, well, how did you come up with your sample size? And those sorts of things. At UAB, we have the Biostatistics, Epidemiology, and Research Design group that's part of the CCTS. We have drop-in clinics, seminars and webinars, and one-on-one consultation. And say start early, right? So I can sometimes help if people come and say, hey, I collected this data, like, can you help me? But it's not always satisfying, right? So I can't always, can't always fix things. And questions, when someone comes to me and starts with, I've collected this data, what's my study design? That conversation doesn't always go very well. So, starting early is good. I'm part of the BIRD group, so you're welcome to contact me. I'm happy to meet with people, talk about study design and analysis issues. And thank you very much.
Yeah, we bring specific question, research design.